So hyperglycemic hyperosmolar non-ketotic coma. Hyperglycemic, how much hyperglycemia? Glucose more than 35 millimole per liter. Hyperosmolar, how much hyperosmolarity? Plasma osmolarity of more than 350 milliosmol per kg. These are the two important criteria to make a diagnosis of HONK with no acidosis and normal pH and no urine, no ketones in the urine. They are common in the elderly patient and patient with type 2 diabetes mellitus. The symptoms are dehydration, weakness, polyuria, polydipsia, progressive loss of consciousness. So in DK, there was acute loss of consciousness. In HONK, there will be progressive loss of consciousness. The treatment is same, IV fluids and insulin. So before moving to parathyroid gland, there are some more topics related to diabetes. There is MODY or maturity onset diabetes in young. Remember that normally type 2 diabetes is diagnosed at age of 40 or above 40 years of age. Type 2 diabetes occurs in patients who are obese, and it is usually diagnosed or manifests at the age of 40 or above 40 years. Now, in some people, type 2 diabetes may occur at a very young age. In people with a strong family history of diabetes, such as history of diabetes in 2 generations, type 2 diabetes can manifest early, such as at a very young age, usually below 25 years of age. This type of type 2 diabetes mellitus is called MODY or maturity onset diabetes in the young. So type 2 diabetes in young people or type 2 diabetes in a young person who is below 25 years of age and with a strong family history of diabetes, your answer will be maturity onset diabetes in the young. Because it is a type 2 diabetes mellitus, so it responds to sulfonylureas. Initially, usually there is no need for insulin. So in Plab 1 exam, someone with either you will be asked to make a diagnosis of MODY, and to make a diagnosis of MODY, the criteria is type 2 diabetes mellitus in a young patient less than 25 years of age who has a strong family history of diabetes. Your diagnosis will be MODY. About the management of diabetes, it can be asked in 2 ways. One way is that they will ask you about what is the next best step in the management of this patient, and as this disease respond to sulfonylureas. So if sulfonylureas is given in the option, then you will select sulfonylureas, and the other option that can be that is that refer the patient to secondary care clinic. So either one of them will be given. Both of them can be the right answer in the management of maturity onset of diabetes in the young. Now, type 2 diabetes in young people is MODY, and type 1 diabetes at a young age is LADA, late autoimmune diabetes of the adults. Type 1 diabetes usually manifests in the childhood. So if someone is diagnosed or someone develops type 1 diabetes at a young age or when he is adult and not in the childhood, then we will call this as LADA, late autoimmune diabetes of the adults. So type 2 diabetes mellitus in a young person less than 25 years of age is MODY, and type 1 diabetes mellitus in young adults is LADA. How we can differentiate between type 1 and type 2 diabetes mellitus? There is a test that is called GAD antibodies test. So if a young patient present to you and his GAD test is positive, GAD is basically glutamic acid decarboxylase. Glutamic acid decarboxylase is a pancreatic enzyme, and pancreas needs this enzyme to function properly. So if the antibodies are positive or present against this enzyme, then it means it is an autoimmune disease. So a young patient with diabetes and his GAD test is positive, then it will be LADA. A young patient with diabetes and GAD test is negative, it will be MODY, maturity onset diabetes of young. Is this clear between MODY and LADA?
Can you
I
repeat
had a
the
question.
question?
Yes, Dr. Shafas.
Um, when you're talking about LADA, is it someone above the age of 10 but below the age of 25, or a teenager? Like, what's the age criteria there when you say young adult?
Age can be 10, above 20. The main thing is that you need to know that if someone is diagnosed with type 1 diabetes mellitus in adulthood, no matter whatever the age is, it will be LADA, because normally autoimmune type 1 diabetes mellitus uh, manifests in childhood.
Okay, so you're saying any type 1 diabetes in adults,
Yes,
but then
any
what
type
about MODY?
yes, any type 1 diabetes that is diagnosed in the adults is LADA, late onset autoimmune diabetes mellitus.
Okay, but then what about MODY that we just spoke about?
MODY is type 2 diabetes mellitus, not type 1.
Got it. Thank you.
How you are going to differentiate if it's type 1 or type 2? Either they will mention it in the scenario or they will give you the result of this test, which is called GAD antibodies test. So a person with diabetes, his age is 25. Let's suppose his age is 20. A person present to you with features of diabetes and his age is 20. Now we are going to decide that it is LADA or MODY. If GAD test is positive, then it means it is an autoimmune disease. So autoimmune is type 1. So we'll say it's LADA. And
Thank
if
you.
GAD test is negative, then it means it's not autoimmune. So it will favor more type 2 diabetes mellitus. So we'll say it's MODY.
Okay. Thank you.
Dr. Musarat, is it clear to you as well?
Yeah, I just wanted to ask about this GATA antibodies test. Now it's clear. Yeah, that's fine. Thank you.
Okay. So someone with hypoglycemia and high C peptide level, the diagnosis will be insulinoma. A C peptide level of 2 nanomole per liter or greater than 2 nanomole per liter usually indicate insulinoma. Now, pre-op management of type 2 diabetes mellitus on oral hypoglycemic that we discussed in surgery as well, but we'll just revise it here as well. So, if major surgery and the patient is taking oral hypoglycemic, so which is the anti-diabetic drug, the only anti-diabetic drug that causes hypoglycemia? Sulfonylurea. So if someone is on sulfonylurea, then and he's to undergo a major surgery, then you will stop the sulfonylurea the night before the surgery. All other medication you do not need to discontinue because none of them can cause hypoglycemia so they can be continued as it is. And if a minor surgery, then we will continue the same routine. And if there is a minor procedure such as upper GI endoscopy, when the patient is on oral hypoglycemic such as gliclazide, then we will omit the morning dose. So oral hypoglycemic such as gliclazide, if a major surgery, then it will be stopped the night before surgery. And if it's a minor surgery such as a minor procedure such as endoscopy, then we'll only omit the morning dose and restart once the patient is eating and drinking again. So this was pre-op management of oral hypoglycemic in type 2 diabetics, and the management of type 1 diabetes, type 1 diabetics. Is that we'll start if there is a major surgery, then we'll start the patient on sliding scale insulin. And if minor surgery, then we do not need to start sliding scale insulin. We just only need to omit the dose on the day of the surgery. In all the cases, we will restart the previous regimen when the diet per mouth is re-established, and we will monitor the blood glucose level 4-hourly. Now, can someone tell me which hormone is released in the stress?
Cortisol.
Cortisol.
Cortisol and growth hormone and all the hormones that can cause hyperglycemia, they are released in the stress, such as glucagon, cortisol, and growth hormone. They all their release increased in the stress condition. So because all of them causes hyperglycemia, so stress such as surgery and infection can sometimes cause hyperglycemia and glycosuria, which is totally a normal response. So when we'll mention that it's stress hyperglycememia, how we'll say that it's stress hyperglycemia, glucose in the urine. Normally there is no glucose in the urine. So if after surgery or after infection, the person has glucose in the urine, then it is most probably stress hyperglycemia. We will order fasting blood glucose level and it will be raised. So our diagnosis of stress hyperglycemia will be confirmed. So to make a diagnosis of stress hyperglycemia, fasting blood glucose will be done. Now, if they ask you how to differentiate between stress hyperglycemia and diabetes mellitus, then the test that you can do is HbA1c. So if they ask you about the test to differentiate between stress hyperglycemia and diabetes, then the investigation is HbA1c. And to diagnose stress hyperglycemia, fasting blood glucose. Remember that stress hyperglycemia is short-lived or temporary. It does not persist beyond 3 days. It resolves usually within 3 days after infection or trauma or surgery. So the test to diagnose stress hyperglycemia and the test as a follow-up test is fasting blood glucose. You can repeat the fasting blood glucose after 3 days and it will be normal. So stress hyperglycemia, the test to diagnose and the follow-up test is fasting blood glucose, and the test to differentiate between diabetes mellitus and stress hyperglycemia is HbA1c. Now, some more complication of diabetes, autonomic neuropathy. It is a microvascular complication of diabetes. Autonomic nerves are damaged due to damage to the microvessels that supplies the blood to the autonomic nerves. So a patient with a history of diabetes, uncontrolled diabetes mellitus, and he has persistent diarrhea or constipation or postural hypotension or impotence. Signs and symptoms of autonomic nervous system dysfunction, then your diagnosis will be autonomic neuropathy. In diabetic patients, two things can cause diarrhea. One is metformin, and the other is autonomic neuropathy. So, if a patient with uncontrolled diabetes present to you with persistent diarrhea, then you will suspect autonomic neuropathy. But if his blood levels are controlled, or blood sugar level are controlled, and he is on metformin, then metformin can be the cause of that diarrhea as well. Diabetic neuropathy, damage to the peripheral nerve, which will lead to loss of sensation, fine touch and pain sensation that usually starts in the toes bilaterally and then it ascends. So there is a stalk and glove pattern of this loss of sensation in the toes and in the fingers. There can also be loss of ankle and jerk reflex, ankle jerk reflex bilaterally. Autonomic neuropathy and diabetic neuropathy, both of them are caused by macrovascular injury, which lead to a damage to the nerves. That's why the person develops signs and symptoms. Another complication of diabetes mellitus is fungal balanitis. Remember that the immunity of the diabetic patients are low, so they are prone to getting fungal infection. So a 42-year-old man presents with polyuria, polydipsia, and raised red spot on his glans venus. The most important investigation to make a diagnosis, because the person is having polyuria and polydipsia, and he is having red spots, which is most likely a fungal infection. So you will check fasting blood glucose level because this person is most likely diabetic. So this is can be sometimes a presentation of diabetic patients with signs and symptoms of hyperglycemia such as polyuria, polydipsia, and low immunity such as fungal infection. So we are done with diabetes, its complication, management, and all the things. Now we are left with hypoglycemia, and hyperparathyroidism, primary hyperparathyroidism, secondary hyperparathyroidism, hypercalcemia, hypoparathyroidism, multiple endocrine neoplasia. So I guess we'll end our session here today. The remaining topics we'll do on Friday.